Okay, Assalamu alaikum everyone. I would like to welcome you all in today's live webinar session being conducted on antibiotic stewardship and antimicrobial resistance. My name is Soban Ahmed Khan and I'm delighted to be your host for today's session. Currently, I'm working as a resident pharmacist under the ASHP International Pharmacy Practice Residency Program at Shaukat Khanam Hospital, Lahore. So today's session, this live webinar, all we've arranged is basically being conducted as a part of World Antimicrobial Awareness Week, which is celebrated from 18th to 24th of November each year. The theme set for 2021 is Spread Awareness and Stop Resistance. So today we are here to discuss the importance of antibiotic stewardship program, to share our expertise with others, and to train other healthcare professionals on how to initiate and effectively run such programs, not only in SKM, but also outside and other healthcare organizations. So before we begin with the presentations, let me give a brief introduction of about what basically an antibiotic stewardship program is and why do we run it and what's the need for that. So since decades, there has been a rising emergence in microbial resistance throughout the world. WHO and CDC declared it an emergency and recognized it to be a global threat to public health. So this threat is even more crucial for developing countries like Pakistan because in such countries we have limited access to advanced generation antibiotics, and moreover we have less sources, so we do not have an access to such antibiotics, and we cannot afford them more. So what we can do is we can be more careful in treating our patients with available resources we have. So therefore, in order to treat our patients with available resources, we need such effective programs like antibiotic stewardship program in order to rationalize the use of antibiotics, and it will help us to control antimicrobial resistance. So as in Pakistan, we have underdeveloped system of healthcare and we have scarce economic resources. So in this regard, Shaukat Khanam is among the leading institutions to implement effective antimicrobial stewardship program that has been updated to modern status and up to the modern standards with each passing time. So it's been more than a decade now since Shaukat Khanam has started its antimicrobial stewardship program, and it's like currently the first in the region to be compliant with 7th edition of JCI, which has the most advanced tender. Now talking about our goals, our goal is to train the healthcare professionals, not only within our hospital, but also outside in the community, with the purpose to spread awareness and rationalize the use of antibiotics, and moreover, other tools which are needed to run and implement and monitor effective antibiotic stewardship program. In SCAM, we believe in teamwork and we strive for the betterment of the patients. Success of our antibiotic stewardship program in Shaukat Khanam is a result of collaborative teamwork, which includes physicians, pharmacists, nurses, microbiologists, and other supporting departments like MIS, housekeeping, etc. So that's the reason why the target audience of today's webinar basically consists of more of the healthcare professionals. So without wasting any further time, I would like to invite our first speaker of today's webinar, Dr. On Raza, who's an MBBS, had his FCPS in internal medicine, infectious diseases, also was a senior instructorship from Shaukat Khanam. He had his fellowship in infectious diseases from UK, and currently he's working as a consultant of infectious diseases and the chairperson of Infectious Control Committee. So please welcome Dr. On Raza.
Thank you very much, Soban, for the kind introduction. Can you hear me? Okay, now just confirm, please, can you see my slides?
Yes, sir, I can see that.
All right. Okay, so I will today just give a brief overview what is antimicrobial stewardship program and how we are doing at Shaukat Khanum Hospital, Lahore. So I will briefly discuss what is antimicrobial stewardship, why it is required, what are the goals, and then an overview at our hospital. So antimicrobial stewardship is the optimal selection, dosage, and duration of antimicrobial treatment that results in the best clinical outcome for the treatment or prevention of infection with minimal toxicity to the patient and minimal impact on subsequent resistance. So this activity actually promotes, as I mentioned earlier in the definition as well, that we need to select the appropriate antibiotic or an antiviral or whatever according to the diagnosis. Then the most important bit is that we are using appropriate dose, not giving the very high dose or suboptimal doses, and then appropriate route and duration of antibiotic. This stewardship or antimicrobial stewardship is required because from 1935 till 2003, there were 20 new classes of antibiotics which were introduced. But since 2000, only 4 new classes of antibiotics have been introduced and 15 new antibiotics. So before 2000, there were more than 70 new antibiotics were marketed and they were in the market available. But since 2000, in the last nearly 21, 22 years, only 15 new antibiotics. And that is one part, but the second part, which is more important, is the emergence of resistance strains like MRSA, vancomycin intermediate Staphylococcus aureus, vancomycin resistant Staphylococcus aureus, and then Enterococci, which are resistant to vancomycin. And then the other spectrum is gram-negative bacteria, which are ESBL and carbapenem resistant Enterobacteriaceae and carbapenem resistant Acinetobacter and Pseudomonas. So the antibiotics which are currently in the pipeline are either from the existing class or they are very broad spectrum. So this is a nice graph which shows the various time periods of antimicrobials timeline. So in the pre-antibiotic era, so in 1900, earlier in last century, the top 3 leading cause of deaths were infectious diseases. And in First World War, there were more deaths because of the infection rather than the battle wounds. But this changed with the discovery of penicillin in 1929. And then the golden age of antibiotics started. So penicillin was widely used during the Second World War for the soldiers, but this led to the penicillin-resistant Staphylococci, and it was declared a global pandemic in 1948. And then, as we can see, that from 1950 till 1970, 20 new antibiotic classes were discovered. So then came the Me Too drugs, and so here methicillin was discovered, and it was used to treat penicillin-resistant Staphylococcus aureus. But within 2 years, resistance to methicillin developed again in Staphylococcus aureus. And from 1970 till 1980, over 60 antibiotics were released to the markets. And currently we are in discovery void time period. And in 2001, WHO declared antimicrobial resistance a global health concern because we are using antibiotics in all the fields, not only in our patients, but also in the agriculture, in the animals, and so on. So in 2013, 131,000 tons of antibiotics were used in agriculture. And as a result, that we were seeing resistance to other antibiotics, but we have found in 2015 resistance to a colistin resistance gene MCR1, and it was first reported there at that time. So it is estimated that by 2050, 10 million antimicrobial resistant related deaths are predicted each year. So how can we help? What is our role? So we can help by conserving the antibiotics by antibiotic stewardship. So There are three main goals of antimicrobial stewardship. The first goal is appropriate antimicrobials with correct dose and duration. Second is to prevent antimicrobial misuse, overuse, or abuse, and then to minimize the development of resistance. So how can we achieve first goal? So we can use the correct diagnosis first. That is the most important part of antimicrobial stewardship, that to diagnose the disease, whether this is a viral infection or bacterial infection, whether the antibiotic is required or not. Then selecting the appropriate drug, then proper dose, delivery route, de-escalation when culture report is available, then to de-escalate the broad spectrum initial empiric therapy to a narrow spectrum antibiotic, and then appropriate duration. How we are overusing antimicrobials. So for example, we are treating viral infections with antibiotics. So nearly 2/3 of upper respiratory tract infections, or more than 2/3, are because of the viral infections, but we still use a lot of antibiotics. Then for using antibiotics for non-infectious processes, and then treating bacterial colonization, which do not require antibiotics, with antibiotics. Then misusing antibiotics by giving broad spectrum antibiotics like carbapenems to patient who is coming from community and never had any hospital exposure, and giving him meropenem for simple fever or infection. And then second part is we fail to adjust antibiotics according to the culture report. And the worst part is antimicrobial abuse, which means that under the influence of pharmaceutical counseling, we are using one particular antibiotic without knowing the spectrum of that antibiotic, or due to other financial interests. So, and using broad spectrum antibiotics and antibiotics, they're increasing colonization. And now we are seeing more infections with resistant organisms and Clostridia, Aedes difficile, diarrhea. And over the last few years, the gram-negative resistance to carbapenems and cephalosporins have increased 10 to 20 times. And this not only increases their length of stay, but also increases the cost per patient. So the basic core elements for developing a comprehensive antimicrobial stewardship program is a multidisciplinary team. So it is not one person's job, as Soban mentioned in his introductory talk, that it's a teamwork, as we have in Shaukat Khan Hospital. So physicians, clinical pharmacists, not necessarily, I mean, preferably with an ID training, but not necessarily an ID pharmacist, clinical microbiologist, infection control specialist, and information system specialist. And they are all the part of this stewardship program. And what does a team look like? So actually the team, so there is a chair of this stewardship team, or leader, or the lead, which can be a clinical pharmacist or a physician. Again, not preferably an ID physician, any physician can take lead. And the hospital administration's role is very important, and their participation in this program is again crucial. And then members from other departments, if you have infectious disease, then infectious disease physician, from the quality control department, from the PNTC committee, and from microbiology lab, medical information system, infection control experts, and hospital epidemiologists. So they all make an antimicrobial stewardship team. There are two strategies for the antimicrobial stewardship. The first is front end or pre-prescription, which we are following at Shaukat Khanum, which means that it requires prior authorization to use a restricted antimicrobial. And then the second strategy is back end or post-prescription, which means prospective review and feedback to clinician to adjust, change, or discontinue antimicrobials, and to advise on the de-escalation of antibiotics according to cultures. So, I mean, as a physician, we all should consider the following facts before prescribing antimicrobials, we should be aware of the spectrum of coverage of that antibiotic, whether the antibiotic covers that particular organism or not. For example, ertapenem does not cover Pseudomonas aeruginosa. Then we should know the pattern of resistance, not only in the community, but also in our hospital. And then evidence or track record of the specified infections. We should have the knowledge whether the particular antibiotic will achieve serum tissue blood concentration, or whether this will penetrate the blood-brain barrier, or CSF will reach to the CSF. And then the allergy history of the patient, toxicity of the particular antimicrobial, then formulation, whether IV or oral should be used, and whether oral antibiotic which we're going to prescribe, it has enough bioavailability. And then the convenience, whether you're using antibiotic. So as a patient, I would prefer once a day antibiotic. So if we have an option with limited spectrum, a narrow spectrum antibiotic with once a day, should choose that rather than using 4 times or 3 times a day. And then obviously cost. So antimicrobial stewardship, actually, it's a balancing act between appropriate initial antibiotic while improving patient outcomes in healthcare, and unnecessary antibiotics and increases resistance and cost. So at Shaukat Khanum Hospital, the antimicrobial stewardship was started in at least 15 years back, but it was it has been computerized and online program since 2012, and on the basis of IDSA guidelines, and we are using front-end or pre-prescription approach. So we have restricted a number of antimicrobials, including antibiotics, antivirals, and antifungals. So what happens that whenever a service prescribes an antibiotic which from this list, it comes to infectious diseases consultants or fellows queues. So this is a screenshot of our hospital information system. So here you can see that this comes as a restricted medicine approval. And when we click on this, we see the list of patients and with the restricted antibiotics, who require restricted antibiotics, and with the details of the particular patient. So it tells us what is the dose of antibiotic for how many days they are asking for, and what is the rationale for that. So we have authorized them to use and restricted antimicrobials for a particular duration. For example, in case of meropenem, which is 8 hours. And during that time, we have to accept or reject it. We can review the charts and then give them the duration of antibiotic. And then we can put our remarks, if there are any, to guide them. For example, if we want to tell them to repeat cultures in 48 hours, or daily blood cultures, or to review antibiotic in 48 hours, and then we can sign it. So that's how the system works at Shaukat Khanum Hospital. So the take-home messages actually are that multi-drug resistant pathogens are becoming more common everywhere. Antibiotic stewardship means to optimize the use of antibiotic, not to police them. We all need to do our part in the responsible prescribing of antibiotic, because it is affecting us all. Should treat bacterial infections, not colonization. We should not treat sterile inflammation or abnormal imaging without signs and symptoms of infections. And we should not treat viral infections with antibiotics. And then the most important part is the limit the duration of antibiotic therapy to appropriate length. Thank you very much.
Thank you so much, Dr. Anraza, for the wonderful overview of our antibiotic stewardship program at Shaukat Khanum Hospital. So just for the audience, I would like to tell everyone, if anybody has a question to ask, kindly do mention it in the comment section below, and we'll be discussing it at the end in the question answer session. Okay, so now let's move towards the second participant, who's Dr. Sumaya Nizamuddin. She'll be speaking on intrinsic resistance in bacteria. She's an MBBS, Harvard FCPS in microbiology, and currently working as a consultant medical microbiologist and head of the section of microbiology at Shaukat Khanum Hospital, Lahore. So please welcome Dr. Sumaya Nizamuddin.
Great. Thank you so much. I hope you can hear me properly. Hello?
Yes, Dr. Sumaya, we can hear you.
All right. Thank you, Dr. Wang. Thank you. So Assalamu alaikum, everybody. My name is Dr. Sumaya, and I'll be speaking about the intrinsic resistance in bacteria. So basically, I thought that perhaps we should look at another aspect of antibiotic resistance and how some prior knowledge about the behavior patterns of some bacteria and their responses to certain antibiotics would be helpful when we are actually managing patients, when we are prescribing antibiotics, and perhaps when we need to make empirical antibiotic choices. So I thought maybe this would be a fresh look or a fresh perspective on how this information can be dispersed to our audiences and how we can obviously revise our concepts and learn the information that I'm about to show in the next couple of slides. So we already know what antibiotic resistance is, and the theme will be discussed obviously throughout the webinar. But basically, antibiotic resistance happens when germs like bacteria and fungi develop the ability to defeat the drugs that are designed to kill them. So that's a simple definition of what antibiotic resistance really is. And there are two types or two mechanisms of resistance. So one of them is acquired, and the other one is inherent or intrinsic. Acquired resistance is when a particular microorganism obtains the ability to resist the activity of an antimicrobial agent to which it was previously susceptible. So it acquired it from an external source. The bacteria or fungus wasn't previously resistant, and now it has become resistant. And that could be, and how does it do that? It could be because of a mutation, or perhaps because it acquired additional genes from an outside source. The other mechanism is intrinsic or inherent resistance. So this is when a bacterial species is naturally resistant to a certain antibiotic or family of antibiotics. And obviously it did this because without the need of a mutation or without gaining newer genes from an external source. And this also means that these antibiotics can never be used to treat these infections that are caused by these particular bacteria. Okay, moving on. So how does intrinsic resistance actually happen? So according to published data that we have, it could be because of lack of affinity of that particular drug for a target on the organism. It could be because inaccessibility of the drug into the bacterial cell, so it cannot go inside. It doesn't have a route to enter the cell. It could be because of extrusion of the drug by chromosomally encoded active exporters. So this means that the drug is being pushed out of the cell and it is not being allowed to be retained to function. And of course, because the last one is because of innate production of enzymes that can inactivate the drugs. Okay, so it has mechanisms to inactivate the drug, and obviously then the drug is not going to function in this particular bacteria or fungus. So some intrinsic mechanisms or resistant patterns are easy to remember and some are not. So for example, there are certain groups of antibiotics that will only work on gram-positive bacteria, and there are certain group of antibiotics that will only work on gram-negative bacteria. So we know that the glycopeptides like vancomycin, and then we have teicoplanin and linezolid and daptomycin, these antibiotics only work on your gram-positive. So they can never be used to treat a gram-negative infection. And then on the other hand, there are certain antibiotics that can only be used to treat gram-negatives, such as colistin and astrinam, and these never work on gram-negatives, and obviously they should not be used to treat these infections. But the only problem arises is obviously these concepts are not always easy to remember. All of these results are not often reported in all microbiology reports. So for example, if the lab is reporting an E. coli, it's not going to report in the results that vancomycin is not going to work on E. coli because it's sort of self-explanatory. But for example, if someone doesn't know this, and if they would like to get this information, there are apps and info guides available online. Obviously, you're more than welcome to call the microbiology staff, and we are all of, if accessible, your pharmacists or your infectious diseases physicians, and of course they would be more than happy to help you in in coming to a decision. But obviously there's a lot of material available online, and most of us already have these antibiotic apps on our phone, and they're very easy to refer to, and you can obviously go back to them and get that information. So tables like these are often found online, and these are usually a very good source to find out whether an antibiotic works or covers a particular organism or not. So if you look at the far left side of the table, as we can see, we have our VREs, our MRSA, MSSA, Enterococcus, our strep. So these come under the category of a gram-positive. So you can see that, for example, vancomycin will work on your MRSA, MSSA, Enterococcus, and your streps, but it's not going to work on your VREs. Linozolid, on the other hand, will work on all of your gram-positives, unless and until obviously that organism has acquired a resistance to that bug. And let's go down to the far right at the bottom. For example, we have colistin over here. As you can see, the arrow, it only covers these group of bacteria, which are the Enterobacteriaceae, your Pseudomonas. Your colistins do not work on, for example, your gram-positives and your anaerobes. They don't. So these cannot be used to cover infections caused by these bacteria. And it would be a good idea to actually have such infographics or such tables on your phones or on your study materials to for easy reference, because these come in very handy when obviously you're trying to build up your knowledge about antibiotics, or when you are confronted with a difficult case where you don't know how to manage a particular infection. Okay, so this screenshot is actually from our CLSI guidelines. So basically, CLSI stands for Clinical Laboratory Standard Institute. So these are international guidelines, and they actually guide the laboratories about how antibiotics should be reported for organisms. So these tables are also very useful. Once again, they're very they are fairly accessible. If anybody needs them, they can contact us or contact a microbiologist, and we'd be more than happy to share. And these are very helpful when it comes to referring to, for example, this particular table is for Enterobacteriaceae. So we can see that, for example, ampicillins are intrinsically resistant. These Citrobacter, Enterobacter, for example, are intrinsically resistant to ampicillin. Your Klebsiella is intrinsically resistant to ampicillin. So whenever, for example, you're faced with a case, for example, let's say a Klebsiella pneumoniae was reported in a urine culture sample, and the report comes back to you and it says that it is Klebsiella is resistant to ampicillin, you can actually, you know for a fact that yes, because it is intrinsically resistant, it's being reported like that. But in case it is reported as sensitive, there are two possibilities that could arise. Perhaps there was a failure in identification or a failure in correct reporting. So you can actually go back and perhaps discuss the report with your microbiologist, that maybe perhaps there's an error over here, and obviously a healthy discussion can actually come out of it. But as I said, such tables are very useful when you're planning empirical treatments, or when you are perhaps tailoring your treatment when there are multiple organisms involved in an infection. So the next couple of slides is just a compilation of these resistant mechanisms. So that could perhaps be useful tools for anybody who would like to know more about these intrinsic patterns. So let's discuss just briefly about the intrinsic antibiotic resistance in gram-negative bacteria. So certain bacterial pathogens that are intrinsically resistant, there are certain bacteria or bacterial families of gram-negatives that can be inherently resistant to these antibiotics. So these could include ampicillin, amoxiclavulinate, certain carbapenems, ertapenems, nitrofurantoin, and polymyxin. Right, and just a recap over here, these antibiotics only work on your gram-positive, so should never be used to treat a gram-negative infection. So, for example, now which bacteria are intrinsically resistant to ampicillin? So these are the groups that are mentioned over here. These are intrinsically resistant to ampicillin, and these antibiotics should not be used to treat these infections. So we have certain Enterobacteriaceae over here. We have our Acinetobacter. Obviously, we have a Pseudomonas and Yersinia and Serratia. Then there are certain bacterial pathogens, gram-negatives, which are resistant to amoxiclavulinate combination. And then we have some of our Enterobacteriaceae, Pseudomonas, Serratia, and Yersinia. Then there are certain bacterial pathogens that are intrinsically resistant to polymyxin. And I think this is a group that everybody should remember. Polymyxin and collicins do not work on these bacteria at all. And these include your Morganella, Protease, Providentia, and Serratia. A special mention about protease. Unfortunately, protease is resistant to multiple group of antibiotics such as the tetracyclines, anticycline, nitrofurantoin, and collicin. So these do not work on protease at all. When it comes to Serratia, Serratia also is resistant to your polymyxins and nitrofurantoins, and it is resistant to various classes of cephalosporins such as class 1 and class 2, but not generation 1 and generation 2 are resistant. Generation 3 are fairly susceptible, but they have to be used with caution, and I'll explain that further. Pseudomonas aeruginosa, once again, unfortunately, intrinsically resistant to various classes of antibiotics such as the ceftriaxones, your basic beta-lactams, ertapenem, tetracycline, tetracycline, Septran, and chloramphenicol. Acinetobacters are also intrinsically resistant to ertapenems, chloramphenicol, astronam, and fosfomycin. Burkholderia cepacia, often reported from your ITUs, from your ICUs, and unfortunately, the Burkholderia cepacia complex is also intrinsically resistant to polymyxins and ertapenems. Another special mention for Stenotrophomonas multifida. This particular group is also resistant to various classes of antibiotics, and that's exactly the reason why we don't report a lot of antibiotic sensitivity results antibiotic options for this particular organism, because it is resistant to various class. And this is one of those organisms that is intrinsically resistant to your carbapenem. So imipenem, meropenem, and ertapenem have been included in this list. Pseudomonas aeruginosa, once again, intrinsically resistant to ertapenem, your tetracyclines, chloramphenicol, and Septran. Moving on to gram-positives. So special mention for Enterococcus. So often enough, we are asked for susceptibility results for cephalosporins for Enterococcus. Now, the thing is, your ampicillin and your penicillin are effective against Enterococcus, but Enterococci have no receptors for your cephalosporins. So cephalosporins actually are intrinsically resistant in Enterococci. And aminoglycosides as well don't work on Enterococcus unless they are high, a high level aminoglycoside is tested in the laboratory. And clindamycin and Septran don't work on Enterococcus either. And I would like to specially mention Listeria as well over here. Cephalosporins don't particularly work well on Listeria either. So this often comes up when you're treating a patient with meningitis. And if you're starting an empirical treatment plan, for example, you are suspecting perhaps Listeria might be an additional cause of infection, and ampicillin is added along with a third generation cephalosporin to cover Listeria. And this is exactly the reason why, because Listeria is intrinsically resistant to cephalosporin. So just a recap over here, as I said, such tables would be very useful if you have them for easy reference when you're managing your treatment plans and when you're handling infections that are caused by multiple organisms. So I think we've covered almost everything. Oh yes, so, just one more thing that I wanted to mention. We should obviously look out for inducible resistance as well, and this comes in very handy when you are dealing with infections caused by the spice A group. Now this includes your Serratia, Pseudomonas, Providentia, indole positive protease, Citrobacter, Enterobacter, and Acinetobacter. Now, basically, inducible resistance of AMP-C actually occurs in these organisms. Now, these particular group of organisms may be reported as susceptible to your cephalosporins, but they are usually avoided when treating these organisms, because these can eventually start producing AMP-C, which are chromosomal beta-lactamases in the presence of these antibiotics, and then eventually become resistant while being on therapy. So in these particular organisms, it is always preferable to avoid using your beta-lactams except carbapenems because of AMC production. So we've recapped almost everything. So I would be happy to take any questions at the if anybody has any.
So that was Dr. Sumaya Nizamuddin. Thank you so much, ma'am, for sharing your views. Now moving towards the third participant of today's session, who's Dr. Azra Parveen. She'll be speaking about acquired resistance mechanism and its management. She's an MBBS, had her FCPS in internal medicine and infectious diseases. She had her fellowship in ID from UK and currently working as a consultant in infectious diseases and consultant of internal medicine at Chota Khanum Hospital, Lahore. So please welcome Dr. Azra Parveen.
Assalamu alaikum, everyone. So I'll be talking about antimicrobial resistance mechanisms and management. Begin with the introduction to AMR and the magnitude of the problem, the factors leading to antimicrobial resistance, and what are the mechanisms, what are the treatment options available, and the preventive aspects. So antimicrobial resistance is not a new problem. It has been there since penicillin was discovered and the Russian Wars began. And Alexander Fleming, in his Nobel Prize lecture in 1945, had predicted the development of antibiotic resistance. And he had said that a time will come when a penicillin would be available for anyone in the shops, and that will lead to the less therapeutic doses of the antimicrobials and leading to antimicrobial resistance. This is the antibiotic timeline, which basically shows the time of development of the antibiotics and the time at which the resistance was discovered. This is a similar picture has been shown by Dr. On. The aim is to show you that the bacteria are very smart, and as soon as the new antibiotics is developed, they develop resistance mechanisms, and they're able to overcome that bacteria and that antibiotic. So the linezolid, like for example, linezolid was discovered in 2000, and the linezolid resistant staph was discovered in 2001. Ceftazidime was discovered in 2010, and there was appearance of ceftazidime resistant staph in 2011. So bacteria are too rapid to develop resistance mechanisms. So the global burden of infections resistant to antimicrobial medicines is growing at an alarming pace. And WHO identified antimicrobial resistance as a growing global threat in 2015. And it is estimated that if the antimicrobial resistance continues at this pace, there will be around 10 million deaths due to antimicrobial resistance by the year 2050. And this is more than the deaths caused by cancer. And this increasing antimicrobial resistance makes the treatment of immunocompromised patients very difficult, like the organ transplant recipients and the cancer patients. WHO in 2017 listed this priority bacteria for which there is an urgent need of developing new antibiotics, and they classified these as priority 1, 2, and 3, depending upon the degree of severity. And this is the priority 1 group, which is called as critical, and this contains all of the highly resistant gram-negative bacteria, the carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas, and carbapenem-resistant Enterobacteriaceae. I would like to share the anti-diagram of Chota Khanum Hospital from the year 2015 to 2020 to show the pattern of resistance for the common organisms, and we can see the sensitivity profile of E. coli for the various commonly used antibiotics. And so in the year 2015, E. coli was quite sensitive to the carbapenems, but 95-96%. It has now gone to 79%. And similarly, piptas was the sensitivity, 78% of the isolates were sensitive to piptas, but now only 60% are sensitive. The sensitivity of E. coli for ciprofloxacin, ceftriaxone has always been low. Fosfomycin and nitrofurantoin have a good susceptibility profile, but the use is limited to UTI. In Klebsiella pneumoniae, here there's not much difference over the past years, but still the sensitivity of this is low, especially for piptas, only 71% sensitivity, and for ciprofloxacin, only 57% aspirates are sensitive, and the sensitivity of ceftriaxone is only 36%. The Pseudomonas aeruginosa has a better sensitivity profile, around 80% sensitivity for carbapenems, and similar for piptas and ciprofloxacin. And over the years, it has remained more or less the same. These are the factors that lead to antimicrobial resistance. The most common is the misuse of antibiotics in humans, and then overuse of antibiotics in animals, overuse of antibiotics in the food industry, antibiotic use in agriculture, poor hygiene, and lack of rapid diagnostic procedures. So some basic definitions: antibiotic resistance is defined as the ability of microorganisms to survive when exposed to antibiotics that usually would kill them or prevent their growth. A bacterial strain is said to be susceptible to a given antibiotic when it is inhibited in vitro by a concentration of this drug that is associated with a high likelihood of therapeutic success. And a bacterial strain is said to be resistant to a given antibiotic when it is inhibited in vitro by a concentration of this drug that is associated with a high likelihood of therapeutic failure. And then the multi-drug resistant isolates are when there is resistance to 3 or more different classes of antibiotics. So resistance can be intrinsic or acquired. Dr. Sumaya has already discussed about intrinsic resistance. Intrinsic resistance is an inherent feature of a species that results in lack of activity of a drug or a drug class. Acquired resistance is something that is acquired by the bacteria. It results from a change in the phenotypic characteristics. So the bacteria that was previously sensitive to an antibiotic acquires the resistance mechanisms and later on becomes resistant. So what are the mechanisms of antimicrobial resistance? Dr. Faisal Mahmood recently gave a talk, and I had noticed that he is in the audience, so I won't be able to explain the way he did, but I'll just make an attempt to explain the mechanisms. So this is a structure of the gram-negative bacterial cell wall, and we can see there is an outer lipid bilayer which contains the porine channels, which is basically a channel for the entry of the nutrients and the antibiotics into the bacterial cell. Then there are the efflux pumps, and this is the periplasmid space, which contains the beta-lactamases. These are various beta-lactam antibiotics available, which include the penicillins, cephalosporins, monobactam, which is estronym, and the carbapenems. So to understand the resistance, again, go back to the structures of the gram-negative bacterial cell wall. So there is an outer membrane in which contains the porine channels. So the bacteria can become resistant to an antibiotic if there is reduction in the number of these porine channels, or if they acquire mutations that bring about a change in this structure of the porine, so that antibiotics do not enter through these, and that sort of the gateway or the channel to entry is blocked. The other minor resistance could be a presence of the efflux pump. So this will actively move the antibiotic out of the bacteria. This is a weaker mechanism, not all of, so some antibiotic is still present inside the cell. Then in the periplasmid space are the beta-lactamase enzymes. So this is the most potent and the most powerful mechanism of resistance. These beta-lactamases will break the beta-lactam ring, and in a way they completely destroy the antibiotic and make it ineffective. So I've already mentioned the production of beta-lactamases, decrease in permeability of the bacterial cell wall because of changes in the porine, efflux pumps, and modified penicillin binding proteins, which is basically a mechanism of resistance for the gram-positive bacteria. This is the umbrella classification of beta-lactamases. We broadly classify them as serine and the metallo-beta-lactamases. And in serine, we have class A, which contains the ESBL, extended spectrum beta-lactamases, and KPC, Klebsiella pneumoniae carbapenemases. Then we have class C, MC, class D contains oxalate, and class B, which is metallo-beta-lactamases, including NDM, New Delhi metallo-beta-lactamases, which are common in our part of the world. So coming on the treatment options are limited and uncertain. So infectious disease consultation should always be taken while managing such infections. So I will first mention about the treatment options which are available in Pakistan. These are not the recommended treatments and not the first line in rest of the world, but these are the options which we have here. The main thing which we use in these resistant organisms is polymyxins. So polymyxin is either polymyxin B or polymyxin E. In Pakistan, we don't have polymyxin B, and we are only using colistin, which is polymyxin E. Polymyxin B and colistin, they both have a similar antimicrobial spectrum, but they are different pharmacologically. Polymyxin B has an easy dose calculation. The pharmacokinetics are more predictable, and the drug levels are achieved more rapidly with polymyxin rather than colistin. But unfortunately, we don't have it here. And polymyxin B is actually the preferred antibiotic for bacteremias. Colistin or polymyxin A is only recommended for UTI. Then we have fosfomycin, which is a bactericidal antibiotic and can be used in combination to treat the government-resistant organisms. We can use aminoglycosides. Pegicycline is at the bottom of the list. We have this available, but it's not the first line. It is not recommended. It is good for skin soft tissue infections and the intra-abdominal infections. It has good tissue availability, but it achieves poor blood levels in serum. So therefore, it's not recommended for bacteremias. And there is, if we have to use pegicycline, it should be only the last resort when we don't have any other option available. It has to be used in a high dose. And remember that there's a FDA black box warning about increased mortality with the use of pegicycline. I would like to mention about the prolonged infusion of beta-lactam antibiotics, because this is something which we can do to enhance the activity of these antibiotics. So it is recommended to use continuous infusion, that is over the entire dosing interval, or as an infusion of 2 to 4 hours. This is based upon the pharmacodynamic principles. As the beta-lactams demonstrate time-dependent kinase. So greater the time, the concentration of the drug is above the MIC, better would be the outcomes. And these are the newer antibiotics which are available in rest of the world. These are the beta-lactam, beta-lactamase inhibitor combinations. So in all these antibiotics, we already have these beta-lactam drugs which are combined with these beta-lactamase inhibitors. So all these antibiotics owe their activity to their companion beta-lactamase inhibitors. And these beta-lactamase inhibitor will inactivate the beta-lactamase enzyme in the bacteria and will make these beta-lactam antibiotics potent or active. So we have ceftazidime avibactam, meropenem viborbactam, imipenem relebactam, and cephalosporin tazobactam. So all these are FDA approved, and there are many in the pipeline. But just to remind again that none of them is available currently in Pakistan. So as the treatment is difficult and we don't have many options, it is important to focus on the prevention of these development of these resistant organisms. And this includes antimicrobial stewardship, infection control, and then minimizing the use of invasive devices. So some basic principles of antimicrobial use, we should start with when you start an initial empiric therapy that is based upon the clinical presentation of the patient and hospital antibiogram. And then once we have more information available and the more microbiological data is available, we always should modify or tailor the antibiotic therapy. We should de-escalate the broad spectrum antibiotics or modify the antibiotics. And it is also important to convert from intravenous to oral antibiotics as soon as the patient is able to start to take orally, except in conditions where the indications whether you need to use intravenous, like for infective endocarditis. Otherwise, every attempt should be made to change from intravenous to oral antibiotics. Then use the shortest effective duration, like if you treat pneumonia with a 7-day course of antibiotics, there's no advantage of using 2 weeks. And then pharmacokinetic monitoring to make sure that adequate blood levels are achieved and also to avoid drug toxicity. And then infection control, Mr. Brown will discuss about this in detail. This includes hand hygiene and the transmission-based precautions. Other than these measures which we take in the healthcare setting, there's some other general preventive measures which are needed to reduce antimicrobial resistance. This includes legislation against the antibiotic misuse, against the poor quality of drugs, and over-the-counter availability of drugs, and the use of antibiotics in animal feed. So to conclude, I will say that antimicrobial resistance is a global threat, and we need a coordinated effort from government, healthcare, and industrial sector. New antimicrobials will not be available in Pakistan for years and will not be affordable. So we must improve our infection control and hand hygiene standards and establish antimicrobial stewardship programs to ensure that remaining antibiotics are used judiciously. Thank you. I'll take the questions at the end.
Thank you so much, Dr. Azra Parveen. Thank you so much, Dr. Azra Parveen, for your valuable guidance. Now moving towards the next participant, Dr. Mohammad Rehan Khan, who's PharmD, had his MPhil in pharmacology and is an American board certified pharmacotherapy specialist. He'll be speaking on effective tools used in antimicrobial stewardship program. So please welcome Dr. Mohammad Rehan Khan.
Assalamu alaikum. Thank you everyone for being here. I will try to explain some important tools that are needed for effective implementation and monitoring of antibiotic stewardship program. The contents that I will try to cover important some pathways that we use. Importantly, the restriction pathway for especially restricted antibiotics that can be different for different hospitals. We use to restrict their use, to rationalize their use, to use some channels to rationalize their use. Then it comes to the appropriateness review of the antibiotics. Then the clinical interventions done by the pharmacists, then some monitoring tools, defined daily dose, days of therapy, antibiogram, drug utilization review, treatment guideline pathways, and pharmacoeconomic analysis. All these are different tools that can be very useful for effective implementation and monitoring of antibiotic stewardship program in any hospital. I try to explain even the government and those hospitals that don't have that much resources, how can they effectively implement the antibiotic stewardship program in their system. So first thing is that every hospital should have some restriction pathway. We have a restricted antibiotic pathway for certain restricted antibiotics that include carbapenems, some antivirals, antifungals like voriconazole, prosaconazole, and different other antibiotics just like vancomycin, teicoplanin, that once they are prescribed by some resident or some medical officer or some non-ID specialist, and they can enter the stat dose at the emergency dose, but for routine administration, they first go into the queue of an ID physician or ID fellow who just review the indication of that antibiotic. If it's really needed, he will approve that for specific duration of the time. If it is not as much indicated or there's no such indication, he will just reject it or with some proper indication that what alternative antibiotic can be used, or if there is no need for any antibiotic. If it is approved, it goes into the queue of a clinical pharmacist who then reviews for the appropriateness review. What is the appropriateness review? Appropriateness review includes all 6 rights of the antibiotics, that you right dose, right time, everything right, then right documentation that is done. Then includes other things that, for example, renal dosage estimate, hepatic dose estimates, any drug interactions, if any formulary cheaper alternative available, all things are being reviewed by pharmacists, critically reviewed by the pharmacist before verifying, because once pharmacist verifies, then it goes into the system and administered by the nurse. These are the different checks. If pharmacist finds any discrepancy, he will make a clinical intervention. I will explain some interventions that are being done by pharmacist. That will go back into the queue of the physician who will review the intervention, and if it is needed, he will accept, and that adjusted dose, the adjusted antibiotic will be administered to the patient. That is necessary for rational use of the antibiotics. Some common intervention that I have mentioned, for example, here you can see vancomycin was entered to a patient, but the culture sensitivity report shows strep pyogenes afterwards, 2 days after vancomycin. Pharmacist did intervention because patient was receiving vancomycin and ceftriaxone. He intervened that please stop vancomycin as ceftriaxone is covering the strep pyogenes, and it was accepted. That you can see piperacillin tazobactam was started for community acquired pneumonia. So pharmacists did expansion for de-escalation to ceftriaxone. Another case, you can see a drug interaction, for example, linezolid was prescribed for a patient. ID had recommended 4 weeks in total, but the MO of the surgery, he entered 4 weeks of linezolid. So pharmacist reviewed everything. Patient had reviewed 2 weeks of vancomycin. All he needed was more weeks of next and oral antibiotic. At the same time, patient was on oral morphine that has contraindication with the line isolate. So pharmacist came up with the alternative option that was cotrimoxazole, and patient was shifted to cotrimoxazole for 2 weeks to complete 4 weeks in total. Then another case, for example, during ID round, ID consultant had reviewed a patient. He reviewed that the line did not need it because the VRE that there in the culture is maybe a colonizer. And primary team didn't see the recommendation or whatever scenario. Pharmacist reviewed very next day and ensured that those orders are executed. And he plays an intervention for the de-escalation of the line isolate. So these are some interventions show the pharmacist, active role of the pharmacist. For rationalizing the antibiotics, especially the restricted antibiotics that we have limited, considering the resistance now, we have to limit their use. So any pharmacist has to play, any pharmacist has to play an important role along with other healthcare professionals. Next are the different tools, for example, defined daily dose or days of therapy that we use for monitoring of antibiotics consumption, especially the antibiotic consumption. First is defined daily dose. Defined daily dose is very simple tool. For example, I will say meropenem dose for an adult patient is 1 gram Q8 hourly. It's mean 3 grams per day. That's the ATC code. Mean 3 grams per day for an adult patient. We use meropenem. It's daily dose. Defined daily dose is 3 gram. So we have to stick to 3 gram, and we use this 3 gram as a ATC code that is there in the WHO site. For example, in any system, if it is, for example, they consume 1,000 injections in 1 month, and admission is 500 patients. So what you do, you all divide only 1,000 with the 3 gram, that is daily dose for a person. You will get around, for example, 1,000, you can get 333. These are the DDDs. But this is, can be affected by the confounders like the population number or such things. So you have to address this thing. For this purpose, we use DDD for 100 patient admissions and DDD for 1,000 patient days. 100 patient admission shows impact of the admissions, and days shows for how many duration the patient stayed, the length of admission. So use both these tools for evaluation of consumption of the antibiotics. But defined daily dose has a shortcoming. As I mentioned, it only addresses the adult population and adult population with normal renal and hepatic functions. For example, defined daily dose for adult patient is 3 gram, but pediatric patient, it would be a less. Patient with renal failure, it would be less. For example, for end-stage daily, maybe 500 mg once daily. So these populations aren't being addressed by defined daily dose. It has that limitation, but still does work in almost all of the hospitals where you have that other population, adult population. Patient days were calculated simply. We calculate by multiplying the duration, average length of stay with the number at which you get patient days, and we used to evaluate the impact of patient days. Next is days of therapy. Days of therapy is something you can say advanced, but it incorporates HIS. Days of therapy has nothing to do with the dose. All it is concerned is for how many days that antibiotic is used. For example, for 7 days, you will count 7 days. For example, 1,000 patients were admitted in month. Those 1,000 patients, only 10 patients receive antibiotics, and each patient received for 7 days. So the days of therapy would be only 70 days. All you have to do, divide with that number, and you will calculate the days of therapy for that specific population, for DOT for 100 patient admission, for DOT for 1,000 patient days, just to rationalize the comparison, because we have to address the number in every quarter or every year. The patient number will be different, so have to compare with one standard, that is 100 patient admissions or 1,000 patient days. We use both these to calculate that standard. Here are some graphs showing. I'll show you the example of the meropenem. It's showing from consumption trends from 2015 to 2020, and we have it shows the effectiveness of our antibiotic stewardship program, different measures that we took to cut down the use of carbapenems, to rationalize the use of the carbapenems. You can see the impact. It dropped from 2015 from, for example, from 108 and 38 DDT per 1,000 patient days from 108 to 38 in 2020. There was increase in 2020 from 30 to 38 because of this COVID pandemic. COVID had impact. More of the patients were infected with respiratory tract and different infections that made an impact. Same was scenario with the vancomycin. Colistin, there was drop in 2019, but again 2020 there was rise because in our system we had AML patients, and although impact of COVID pneumonia was there too. Imipenem, there was rise because some patients earlier, imipenem, we are using that much imipenem frequently, but because of the hepatic derangements, we preferred imipenem over meropenem in certain patient population that were having high bilirubin. In that patient population, we preferred imipenem, and there was also rise in ertapenem in 2020 because we preferred patients at home. We discharged patients at ertapenem. Those patients who could be discharged at ertapenem, considering we were limiting the number of admitted patients during COVID pandemic. So whoever patient we could think that he or she can be discharged home at ertapenem, we would prefer to discharge at the keeping in the hospital, considering the risk of acquiring COVID and these things. That's why. You can see the all analysis based on the antibiogram and above data, we can analyze our things. This is how we analyze our 2020. We can make analysis on base of antibiogram development further and DDD, that how things impact our system and which measures we can take. For example, for vancomycin, we saw that there were more number of SSIs. So we started decolonization. We proposed decolonization protocol to counter MRSA infections, especially the post-surgery patient, even other patients who were MRSA colonized. Decolonization protocol was proposed, and we have implemented in 2021. I hope we will see a drop in the trend of these antibiotics in 2021 with the impact of decolonization protocol and other measures we have taken. Here are some comparison. For the hospital, those hospitals that don't have the access to HIS, because DOT needs HIS and computer system, but DDD you can do even in the simple government hospital. All you need is how many vials of vancomycin or meropenem we have consumed, number of admissions, and you can calculate the DDDs. But if you can't calculate DOT, you can go with the DDD. You can see the graphs. I have compared last 6 quarters from first quarter of 2020 to the second quarter of 2021. In these 6 quarters, consumption trends of different antibiotics, there is variability, but there is no major variability. So you can say that in other hospitals that they say that we can't implement effective monitoring because we don't have HIS. Look, you can do it. If you can't apply DOT, you can go with DDD. DDD will work fine. It will work for you, and you will get the thing done to the DDD too. So all you have to do is implement it properly. PIP test just showed the impact of second quarter. There was COVID pandemic on the PIP test use. And this analysis, again, we do analysis each and every quarter of each and every year that ends. We do analysis for effective utilization, effective steps that can be taken to counter these things. These are the antibiograms that are explained earlier. We use antibiogram to coordinate with our consumption trends and all such things to ensure effective measures. We use antibiograms yearly and quarterly to have a check on the systems pattern. We also look at the number of the cultures to keep an eye on the number. The number increases, why it increases. We take appropriate steps to counter those numbers, just like I mentioned. These are the assessments. Then is drug utilization review that is done in yearly basis, and whenever needed, we do. The basic purpose is to see that the antibiotic use, especially of restricted antibiotics, is as per hospital standards. And if it is deviating from the standards, we come up with a report of the DUR. We look for why it has been deviated and take measures. This is ASP initialization report. Before ASP DUR was done in 2011, and shows rationality of 35%. After implementation in 2 different departments, you can see the difference of rationality. In chemo it was 75%, in IPD it was 96%. Over a decade, our rationality, you can see currently in recent 2020, even in the COVID pandemic, use of our restricted antibiotics was rational. 96% was our rationality in admitted patients. We use one thing, the treatment pathways that are there in our T guidelines, in our HIS, so that if any fellow, any resident, any physician who have any confusion, he just go to the, for example, he has to go for urinary tract infection, he will open urinary tract infection, and we have formulated our guidelines, taking help from the IDSA, different other international guidelines, but we have modified them based on our antibiogram in consultation with our ID consultants, microbiology team, and other all effective team members. We have sit together to finalize, formulate these to ensure rationality of antibiotics in our system. We do pharmacoeconomic monitorings. We have these studies just to see the impact of antibiogram, overall cost of our antibiotic use. You can see the drop in the cost. In 2015, it was 8.84 billion we spent on vancomycin. In 2017, we were spending only 5.1 million. Same for meropenem, we were spending 21 million. In 2017, we were spending 13 million. There was cut in the amount spent on the antibiotic usage. Thank you very much for being able to see that light despite all the darkness. And our efforts are to promote antibiotic stewardship not only in our institution, but throughout our community, in our country, to rationalize the use of antibiotics to counter the menace of antimicrobial resistance. Thank you very much.
Thank you so much, Dr. Mohammad Rehan Khan, for your valuable guidance and sharing your expertise. So now I would like to invite our last speaker of today's session, Mr. Imran Alalo, who will be speaking on infection prevention measures for healthcare-associated infections. Mr. Imran Alalo is a US board-certified infection control nurse and is currently working as infection control practitioner at Shaukat Khanum Hospital, Lahore. Please welcome Mr. Imran Alalo.
Thank you, Subhan. So my name is Imran, and I'm here working as an infection control practitioner. So today I'm going to discuss about the infection prevention measures for healthcare-associated infections. So the healthcare-associated infections are a threat to patient safety, and its prevention should be the top priority for healthcare organizations. By the end of this presentation, you will be able to understand the definition and types of healthcare-associated infection. I will show you a model to understand the infection disease process, which is often called a chain of infections. And later on, I will present you how to decrease the risk of infection transmission through standard precautions and care of bundles. So first, we will see the definitions of a healthcare-associated infections. So healthcare-associated infections are infections that patients can get in a healthcare facility while receiving medical care. Healthcare-associated infections are those that are not present or incubating at the time of admission to the hospital, but are temporarily associated with admission or a procedure performed in a healthcare facility. We will see the types of healthcare-associated infections I have breakdown in the three categories. So the first is device-associated infections, procedure-associated infections, and healthcare-associated pathogens. So infections can be associated with the devices used in the medical procedures, such as catheters, such as central lines and ventilators. So these healthcare-associated infections called COTI, catheter-associated urinary tract infection, CLABSI, central line-associated bloodstream infection, and ventilator-associated pneumonia. So a surgical site infection is an infection that occurs after surgery in the patient's body where the surgery took place. So infection may occur after the surgery. So we will call them surgical site infection. So few of the other infections may occur with the related to disease and organisms in the healthcare setting. So we have called them MRSA, VRE, MDROs, and other multi-resistance organisms. So I have categorized in this third category. If we see the burden of healthcare-associated infections, the USA CDC estimate that on any given day, 1 in 31 hospital patients and 1 in 43 nursing homes residents has an healthcare-associated infection. If we see the WHO in 2019, healthcare-associated infection fact sheet reported 100 million patients affected each year globally. The healthcare-associated prevalence was estimated in the ranges between 3.5 to 12% in developed countries and 5.7 to 19.1% in low and middle income countries. So understanding the components and the chain of infection, we will discuss about the processes of how the disease goes to the one area to the other area. So understanding the components of the infection disease process or chain of infection is critical to prevent or mitigate infection transmission. And the first component is the causative agent. The causative agent is a microorganism which has the ability to cause disease such as bacteria, virus, and fungi. The reservoir is a place with which infection microorganisms can grow and reproduce. The portal of exit, the path by which the infectious agent leaves the reservoir. And the fourth component is the mode of transmission, the method of transfer by which the organism moves from one place to another area. The portal of entry and an opening allowing the microorganism to enter the host, and a susceptible host person usually lacking effective resistance to particular pathogens. So if we see the disease has to pass connected with each chains connected. So to go to the susceptible host, the causative agent, the reservoir. So these are the areas where the organisms are grow. So we need to break these chains. So by breaking of these chains, we need to follow the standard precautions. The component of the standard precautions are aimed at breaking the cycle of infection by interrupting the method in which transmission occurs. So infection can be prevented between the healthcare personnel, patients, and environments. So the first component of the standard precaution is hand hygiene. It has been accepted as the single most important measure to prevent the transmission of infections, and it is a critical component to reduce the risk of healthcare-associated infections. So we need to follow the hand hygiene whenever we are going into contact with the patients. We must follow the hand hygiene. So keep in mind the 5 moments of the hand hygiene. So before touching the patient, after touching the patient, before clean aseptic procedure, after blood and body fluid exposure. Now, these are the 5 components which are very important for the safety of the patient and for the safety of healthcare workers. So second is important thing is the respiratory hygiene and cough etiquettes. Again, the respiratory hygiene and cough etiquettes limit the spread of respiratory infections. So we can, in this way, we can cover all the respiratory diseases we can prevent to our patients and to healthcare workers. The third thing is very important for the personal protective equipment. So whenever you need to use the selection of PPE is made based on the task being performed and anticipated level of exposure the employee is expected to encounter. So we need to, again, judicious use of the PPEs. The fourth one is the safe injection practices are essential to ensuring both patients and healthcare personnel safety. Healthcare personnel should always use a sterile single-use disposable syringe for each injection given. And the fifth component is safe work practices. Healthcare personnel must use a barrier for resuscitation, such as mouthpiece or a resuscitation bag. For the patient placement, in the event of increased risk of transmission of microorganism, the patient should be placed in a single patient room. And for the last and very important thing, for the environmental cleaning and disinfection of all surfaces, equipment, and devices in patient care areas are very important for the prevention of transmission of healthcare-associated infections. So what are the strategies for prevention of the device-associated healthcare infections? So the Institute of Healthcare Improvement has published evidence-based guidelines to prevent the healthcare associated related to the devices. These set of guidelines are called bundles. A bundle is a structured way of improving the processes of care and patient's outcome. A small, straightforward set of evidence-based practices, when performed collectively and constantly, have been proven to improve patient outcomes. So I will show you the few bundles. So wear prevention bundles, these are the 5 parameters. The elevation of the head of the bed. The head of the bed should be elevated at the angle of 30 to 40 degrees for prevention of aspiration. So if we implement all these bundle parameters, the daily sedation location, then assessment of readiness to attribute peptic ulcer disease prophylaxis, deep venous thrombosis prophylaxis, daily oral care with chlorhexidine, it significantly reduce the ventilator-associated pneumonia. So in Shoka Hospital, we have a checklist on this care bundles, and we are monitoring daily. For the collapse prevention bundles, again, these are the 5 parameters. So perform hand hygiene before insertion of central line, maintain maximum sterile barrier precautions upon insertion. The person who is going to insert, we must need to wear a sterile gloves, sterile gown, cap, mask, and use the large sterile tray. Also need to use appropriate skin preparation, which is recommended for chlorhexidine. 2% optimal site selection is also very important. Avoid femoral vein, especially in adult patients. Daily review of central line necessity and removal of unnecessary lines. So we see the COTI prevention bundles. These are the 4 parameters of the COTI prevention bundles. Avoid unnecessary urinary catheters. Insert urinary catheters using aseptic technique. Maintain urinary catheter based on recommended guidelines. Review catheter necessity daily and remove promptly. So these 4 components are widely acceptable as the best method to reduce the incidence of COTI. And Shoka, we are also using the SSI prevention bundles. So hair removal, so clippers should be used to remove the hairs. Bathing for skin decolonization, glycemic control, normothermia, antiseptic prophylaxis, surgical antibiotic prophylaxis. So we are using these prevention bundles for SSI patients, and we are also monitoring these care bundles. So, and then the surveillance is very essential component for the infective infection prevention and control programs. So in SKM, where IC team is monitoring care bundles, and the results of the outcomes were shared with the concerned staff, with the doctors, with the managers. So, and the improvements to improve the strategies, so taking the improvement strategies. So when we are discussing about the monitoring the COTI collapse back, so these are the, we are monitoring in this formulas the total numbers of healthcare associated infections divided by the total number of devices days multiplied by the 1,000. So in this way, we are calculating our COTI collection bundles. And for the total surgical site infections, we are see that how many surgical site infections are occurred divided by the total number of surgeries and multiplied by the 1,100. So in this way, we are conducting the surveillance reports are shared with the managers, with the surgeon. So afterwards, we take the improvement strategies. So this is really helpful in Shoka Hospital, and I will recommend to all other organizations to follow the surveillance and follow the guidelines. So again, together, this is very important that to remember, keep in remember that healthcare associated infection can be preventable with the good infection control practices, and with the help of other team members, we can reduce these healthcare associated infections. Thank you very much. If you have any questions, you may ask.
Okay, so ladies and gentlemen, as we're almost there and we're done with the presentations, so now I'd like to begin with the question and answer session. I hope we have the panelists here, so everyone kindly unmute your mics. And one by one, I'll be asking the question from each participant, and we'll be proceeding with this session now. Okay, so the first question is for Dr. An. It's by Dr. Shoaib Shamaz, and he asked, which guidelines are being used in Shaukat Khanum Hospital for antibiotic stewardship implementation? Sir, could you hear me? Sir, kindly unmute your mic. Sir, we cannot hear you.
No?
Now I can hear you, sir. Kindly answer it now
Okay.
again, please.
Okay. We implemented IDSA guidelines for antimicrobial stewardship at our hospital.
Okay, so the answer is IDSA guidelines being used for implementation of ASP in Shaukat Khanum Hospital, Lahore. So the next question is from Aisha for Dr. Sumaya Nizamuddin, and she has asked, can you please specify the names of broad spectrum antibiotics that are resistant to both gram-positive and gram-negative bacteria?
So let me just have a look at the question again. Is she asking about resistant to both antibiotics? Sorry, both classes of bacteria?
I think that should cover both antibiotics.
I think that
Well,
might
it's
have been
mentioned.
the question.
Both bacteria, gram positive and gram negative.
It was mentioned as resistant to both.
No, it's a wrong question.
So I think, for anything that is not an antimicrobial will not work, as not an antibiotic will not work on gram positive or gram negative. For example, if you use an antifungal, it's not going to work on gram positive or gram negative, or an antiviral is not going to work on both of the classes of both classes of organisms. Does that, I hope that makes sense.
Okay, fine, okay. Well, I was also confused with the question, but I thought of asking it. So the next question is for Dr. On, and the question is, do you have handshake strategy implemented in Shaukat Khanum Hospital?
No, we have not yet.
Okay, so don't have it.
No.
Okay, so no handshake strategy applied. And the next question is for Dr. Rehan. Okay, so just hold on a second, please.
Do we use dot per 1,000 patient days in our system? Yes, we do dot days of therapy or per 1,000 patient days in our system. We use two tools, dot per 100 patient admissions and dot per 1,000 patient days for monitoring of antibiotic consumptions in our system. We use it for carbapenems, including meropenem, imipenem, ertapenem, vancomycin, teicoplanin, piperacillin tazobactam, and colistin. We are using DOT for these antibiotics consumption trends in our hospital.
Okay, thank you, Mr. Rehan. So the next question is from Mr. Imran Alalok, and the question is, what's the prevalence rate of infections in Shaukat Khanum Hospital?
MRSA.
Of MRSA infections.
For MRSA. So currently we see in the Shaukat Khanum Hospital, the MRSA trend going up. So, and we are taking as well, I have mentioned that we are monitoring in our hospital. So the MRSA rate is increasing in hospital. So we have breakdown this in our in patients. So we see observe that most of the cases are coming from the community. So that's why the MRSA rates are going up in Shaukat Khanum Hospital. So further, we are also taking the strategies, different strategies. We have introduced a MRSA decolonization protocols in Shaukat Khanum Hospital. So, and we are hoping that it will be improved in future.
Okay, thank you, Mr. Imran. So the next question is for Dr. On Raza, and the question is, how often are antibiotic stewardship program rounds done in a week? And who does the program report to? And what's the intervention acceptance rate in Shaukat Khanum?
Okay, so antimicrobial stewardship rounds are done daily by from Monday to Friday by clinical ID pharmacists, along with ID physicians, and we review all the restricted antimicrobials. And then, as I showed in my presentation as well, that we receive a list of restricted antibiotics, and then we provide them feedback. And the clinical pharmacists, they review the dose and appropriateness of all the antibiotics. And this program reports to Infection Control Committee, and the ID pharmacist that presents the data for related to antimicrobial stewardship program activities. And intervention acceptance rate at SKM is around 90% for the last few quarters. Now it's around 90%.
Okay, thank you so much. Now, the next question is for Mr. Imran. Which strategies are implemented to reduce the risk related to needle sticking?
Okay. So again, as we are mentioned that we are monitoring and we are conducting surveillance in Shawhanam's hospital. So for needle stick and sharp injuries, we logged all the needle stick injuries. And for the prevention strategies, we have taken the different strategies, such as you could see in the bedside. We have given the bedside trolley with the sharp container with the bedside trolley. So when the nurses are going to the administering the medication, so one of the strategies is that immediately they dispose in the sharp container. So this is the one strategy. The second thing is we have taken different strategies. So one is that we have introduced the combi stoppers. We have stopping the nurses to take the needles into the bedside. So they are applying the combi stoppers. But the other thing we have taken the strategy to keeping because there are some needle stick injuries occurred in the surgical department. So we have given them education sessions how to handle and how to doing a suturing while they are taking care of the patient in the surgical side. So in that field, during that field, we have introduced, they need to announce when they are giving the shots to the other healthcare workers. So they are announced loudly that this is a shot, so they need to be vigilant at that time. So other thing we have taken the strategy for the housekeeping also. The house attendants, we have taken the education sessions with the house attendants, and we have given them how to handle and care with the sharps boxes and with the waste. So, and meanwhile, we have taken another strategy that we have starting the rounds to see the segregations of how the staff is disposing of the clinical waste. So these are the different strategies we are actually taking, and this is all depends of the type of categories which are coming in the needle stick, how the needle stick injuries are reported. So on that base, on that report, we are taking the strategies. So again, this is a different, in Shawhanam we are taking these strategies, but it may be different in this other organization. Thank you.
Thank you, Mr. Imran. So the next question is for Dr. Azra, and the question is it safe to jump directly on third generation antibiotics in infants for a simple chest congestion with fever or no, especially when he had not received any antibiotic ever before?
Okay, so the answer to this question is no. Though I'm not a qualified person to speak on this, since I'm an adult infectious disease specialist, not a pediatric one, but still we all know that these chest infections in children most commonly are because of viral infections, and really antibiotics are not indicated in the first instance. And really they have to be seen and then assessed based on the presentation of the lab data, and then only then we should start antibiotics, not in the first instance.
Okay, thank you. Dr. Azra, another question for you. How new antibiotics are included in ASP program?
So all these new antibiotics, they all are based on the type of beta-lactamase which is present. So really we need to know which beta-lactamase is present in that bacteria. We need to have that molecular or the gene expert to detect that carbapenemase or that beta-lactamase present. So we need to have information about that. So that is certainly not being done in Pakistan. And what we generally, the information which we have at present is that basically in Pakistan, it is like, it is the NDMs, the new Delhi metallo-beta-lactamase, which are more prevalent in our part of the world. So based on that, we can make a strategy of using the antibiotics which are more like effective for these, which will be ceftazidime and avibactam in combination with STNM. But since we don't have available at this time, so like once we have these developments, that can make a strategy, but this will all depend upon the type of patent base which is present.
Okay, thank you, Dr. Azra. So the next question is for Dr. Rehan, and the question is, which are the audited antibiotics in Shokathana?
First, I will just continue the earlier question. We, as doctors, we follow this path. Along with it, all those drugs are approved from the Pharmacy and Therapeutic Committee. Once Pharmacy and Therapeutic Committee, in which ID consultants are member, once they are approved through Pharmacy and Therapeutic Committee, then they are part of the formulary and part of the antibiotic stewardship program, restriction policy. Everything is approved through Pharmacy and Therapeutic Committee. Next is audit. We do a DUR of the restricted antibiotic. Generally, as I told earlier, the restricted antibiotic include classes, carbapenems, anti-MRS antibiotics, vancomycin, teicoplanin, some other antibiotics, peptides and colistin, and some antifungus. But our focus is if there is any deviation from the practice, or if there is any increase in the consumption of certain antibiotics, we do DUR to check if there is rational use of these antibiotics. We did check this rationality during COVID pandemic for certain antibiotics, just like, for example, ceftriaxone, azithromycin. So we generally do for restricted antibiotics, but it is not limited to restricted antibiotics. We change it as per our need to review the consumption, rationality and appropriateness of use of different antibiotics.
Okay, thank you, Mr. Rehan. And another question is also for you. The question is, what is MRSA decolonization protocol?
Well, MRSA decolonization protocol was approved from Infection Control Committee, keeping in view to control, colonizer MRSA related infections, especially post-surgery patients and certain patients, immunocompromised population that were colonized with MRSA. The purpose of this protocol was to reduce the carrier to counter the MRSA in those that include full body bath with chlorhexidine. We use chlorhexidine bath for decolonization of body MRSA, and we use earlier recommendation was for mupirocin, but as we didn't have mupirocin, the second choice in the CDC guideline was iodine. So we are using iodine for nasal decolonization. We are doing nasal decolonization and full body decolonization through this protocol. We use iodine for nasal decolonization, and we use chlorhexidine bath for body decolonization. Around this protocol, it goes for 5 days pre-surgery or even for any such procedure, so that there is to reduce the risk of MRSA infections in wound and these things.
Okay, thank you. The next question is for Dr. On, and the question is, which antibiotic guidelines are used in SCM, and if they are used, so are they implemented, and since when?
So we follow mostly IDSA guidelines for various infections, but based on our own antibiogram and our trends of infection and sensitivity patterns at our hospital, we have come up with our own guidelines because we have a unique population and they're cancer patients. So for example, for urinary tract infection or for chest infections, so we have come up with our own guidelines based on our hospital antibiogram with the help of microbiologist, clinical ID pharmacist and ID physician. We all sat together and we came up with the guidelines for these infections. Mostly we use IDSA guidelines because at national level, I doubt we have very robust guidelines for various infections. So because we don't have lack of evidence and data for our country for various organisms.
Dr. On, the next question is also for you. And the question is, vancomycin and meropenem adjunctive therapy is justified or not? And if it is, or if it's not, so why? So kindly unmute your mic. Dr. Not audible, sir.
Hear me now?
Yeah, I can hear you now.
I don't know, maybe there's something wrong with the headphones. So that really depends on the situation, on the clinical scenario. So if someone comes in with the febrile neutropenia and he is septic, he has hypotension and he looks unwell. And so obviously at that time, this is a time because patient is septic, unwell, hypotensive. So at that time, we can start empirically meropenem and vancomycin. This meropenem again, because we used to start piptaz, but based on our antibiogram, we have decided to change the antibiotic from piptaz to meropenem if the patient is unwell. So at that time, we can use empirically both of these antibiotics. But once we have the culture results available, maybe when we should review this combination in 48 hours, once we have more information available, like more culture results are available, and then we should de-escalate. So we can use both of these antibiotics. There is, no contraindication as such, but the idea is to always review why we have prescribed it and then de-escalate the therapy or discontinue vancomycin if it is no longer required and there is no MRSA or vancomycin sensitive Enterococcus is grown in cultures.
Okay, so the last question of today's session and the question for Dr. Azra. The question is, can we switch the patients to oral linezolid after IV vancomycin course? And if not, shouldn't we switch IV to oral at all?
So this depends upon the indication. So if we are treating MRSA bacteremia, then probably we'll go on with IV vancomycin. But if we are treating pneumonia or if we are treating a skin soft tissue infection, then once the patient is stable to take oral, then probably we can switch from IV to oral. So it all depends upon the indication for which we are using.
Thank you, everybody. So I would like to conclude the session. Before concluding, I would like to thank you all, the team, the Shaukat Khanam Antibiotic Stewardship Program team, the panelists, Dr. Al Raza, Dr. Sumia Nizamuddin, Dr. Azhar Parveen, Dr. Rehan, and Mr. Iran Alalok. I hope today's session would have been greatly helpful for all of us, and we will try our best to spread awareness regarding the rationalization of the use of antibiotics, and we'll play our roles in controlling antimicrobial resistance. So thank you everyone for participating and attending the session. Allah Hafiz.
Allah Hafiz. Thank you very much.
You're welcome.